Hello and welcome to the Alabama Public Health Training Network. Selective Serotonin Reuptake Inhibitors, also known as SSRIs, are commonly prescribed for a wide variety of conditions, including depression, anxiety, and other mental health conditions. Today we will discuss the role of SSRIs in therapy, including side effects and interactions. Thank you for joining us today for our program, SSRI Pharmacology Update for ADPH Nurse Practitioners. Our objectives for today are to define selective serotonin reuptake inhibitors and discuss their role in therapy, discuss the attributes of SSRIs to include side effects, interactions, and so forth. Also, we'll discuss effects on pregnancies, nursing mothers, and children, and the dispensing role of nurses and nurse practitioners in the Alabama Department of Public Health, and identify the nurses or nurse practitioners' responsibility in drug counseling of patients and interactions with patients and other drugs. If you have a question about anything being discussed today, please call or email our faculty presenters during our live broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses for today's program. The ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive credit for this training, you must watch the entire program and then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 1 year and will expire on November the 30th, 2015. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of the products. Please note, the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by ADPH should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdiction or agency. I'm Charles Thomas, State Pharmacy Director, and with me today is Lindsay Leon, a pharmacy intern with the Medicaid Pharmacy Division of Alabama. Welcome and thanks for joining us today. As we get into our program, we would like to mention that we have a lot of material to cover, and when we get to the questions, we would ask that you try to hold the questions till toward the end in order for us to cover the material. And if any question can't be answered or there is not enough time, we will be more than happy to answer your question through email or telephone call after the program. So we'll get started right now into our program. Serotonin, or 5-hydroxytryptamine, 5-HT, is a monoamine neurotransmitter. Biochemically, it's derived from tryptophan. Serotonin is primarily found in the gastrointestinal tract, platelets, and in the central nervous system of humans and animals. Modulation of serotonin at the synapses is thought to be a major action of several classes of pharmacological antidepressants. Serotonin is a well-known contributor to feelings of well-being. Some people also call it the happiness hormone. 20% of it is synthesized in serotonergic neurons in the central nervous system, where it has various functions, which include the regulation of mood, appetite, sleep, as well as muscle contraction. It also plays an important role in postprandial satiety, anxiety, sleep, mood, obsessive-compulsive, and impulse control disorders. Decreased serotonin activity, either by tryptophan depletion or serotonin antagonist, can contribute to an increased food take. Increase in serotonin is needed to avoid depression, which results when certain brain chemicals or neurotransmitters get out of balance or are low in this case. The mechanism of action is not fully understood, but it involves selective serotonin reuptake blockade at the neuronal membrane, thus enhancing serotonin effects and concentration in the brain. Initially, the availability of serotonin is increased in the somatodendritic area. However, during chronic use of SSRIs, serotonin autoreceptors are downregulated and desensitized, which allows for an increase in serotonin release in the axon terminal synapses. Due to the increase of serotonin in the synapses, there's an increase in neuronal impulses. SSRIs prevent reabsorption or reuptake of serotonin back into what we call the sending neuron, and therefore more serotonin is available between the neurons in the brain to perform its function. And a greater reduction in serotonin contributes to depression. The SSRIs differ from each other by the degree of selectivity for the serotonin transporters. Most of them share similar indications, and we'll show you a little bit later what some of the minor differences are. To inhibit reuptake of serotonin by serotonin transporters located in the synaptic neurons, SSRIs increase available serotonin in the brain. The exact mechanism is not known. However, members of the class differ in degree of selectivity for binding to the serotonin transporter. There's limited activity in other receptors that provides a more favorable adverse event profile compared with tricyclics. Now, here is a pretty graphic illustration of what I have just said, and this is a picture of a presynaptic serotonin neuron and a postsynaptic neuron. As you can see at the top of the picture there, tryptophan, which is ubiquitous, is in the neuron, and it's transformed or synthesized, if you will, into serotonin by tryptophan hydroxylase. And the serotonin encapsulates in a vesicle. The vesicle migrates to the edge of the neuron and releases serotonin into the synaptic cleft, which is then available for pickup and transport by the postsynaptic neuron to other areas where it actually does its job. As you can see on the right-hand side there is a synapse that picks up the serotonin in the synaptic cleft and reabsorbs it back into the presynaptic neuron. Or, as we call it, it is reuptaked back into the neuron. And so it circles. It's released, and it goes to synapse, and it is reuptaked back into the neuron. Well, what happens is, when too much of it is been reuptaked, you get a reduction in serotonin, which is available for use by the other synapses there. So if an SSRI, which is a selective serotonin reuptake inhibitor, is introduced, it selectively prohibits the reuptake of the serotonin back into the presynaptic neuron, and which makes more serotonin available for use by the other neurons. So, as you can see, there are a lot of things. This is a busy slide. There are a lot of things that can affect how the serotonin is produced and does its job in the body. For example, if an SSRI is not being utilized and the serotonin is being reuptaked back into the presynaptic neuron, there's going to be a shortage or reduction of availability of serotonin for its use. So, and that's when you employ an SSRI to selectively block some of those sites. If you use too much serotonin or too much of the sites are blocked, then there may be an excess of serotonin, which could lead to serotonin syndrome, which we're going to talk about later on. So it's a balance of how it is released and taken up and utilized by the body. Which drug to use depends a lot on several factors. First of all, drug interactions. Drug interactions are a big consideration. As an example, we have listed here citalopram, which contributes to QT prolongation. So you wouldn't want to use citalopram with drugs that do the same thing. For example, fluoroquinolones. Use along with it may contribute to more QT prolongation. Also, a patient's previous response needs to be considered. Patient-specific characteristics such as young, old, are they pregnant, have they had problems before, and so forth. And also other drugs that metabolize or inhibit in the CYP450 isoenzyme system. SSRIs are a newer antidepressant as things go. They're second generation, and basically they have fewer side effects than first generation antidepressants, a couple of which we have listed here, tricyclics and MAO inhibitors. Other second generation antidepressants besides SSRIs or SNRIs include bupropion and duloxetine, which are in a different class. SSRIs are generally chosen as first-line antidepressants due to their safety and overdose, improved tolerability. They work well in most people and have evolved sort of the starter drug of choice in a lot of folks. Other first-line agents include SNRIs, selective serotonin norepinephrine reuptake inhibitors, bupropion and mirtazapine. Treatment selection on individual patient characteristics includes comorbidities, concomitant medication that the patient may be taking, an individual or strong family history of response to a particular medication, and patient preference. And as we'll mention later, maybe cost. Maybe the patient has seen it on TV and they just want to try it. Recommendations generally are for SSRIs as monotherapy for patients who are at stage 1 depression. Citalopram and fluoxetine should be avoided in patients with QT prolongation or in patients who are taking other drugs that increase the QT interval. And it's generally not recommended with MAO inhibitors, nor with patients who have bipolar order due to increased likelihood of precipitation of an episode. You need to avoid SSRI therapy in patients who have closed-angle glaucoma because of increase in intraocular pressure. Antidepressants versus placebo, most studies that are not done in a primary setting, and there's not a lot of studies to show it. In primary care, there's a 12-month depression prevalence of 18.1%, but patients with depression in the primary setting often present with somatic, all of those symptoms there, and it's difficult to evaluate and tell about placebos. So there's not a lot of information about that, although some people try them and get some kind of results. Now here's a nice little chart that I've prepared here, or that I found in the literature in Walter's Kluwer, that lists the SSRIs down the left-hand side, and the other part of the chart lists the other things that are shown there. The initial dose of the drug and the dosage range on a couple of them are shown on this chart. What I want to mention up front here, though, is that while these charts, and we have some other charts and so forth, these charts and other aids like this to help with organizing your thoughts about some of these drugs, the best reference that I recommend is the patient information leaflet that comes with the medication. The patient information leaflet has the latest information from the manufacturer. It has all the information that we're going to be giving today about the specific drug that it's in, and it's a legally recognized reference. Other references that you may be able to get that show all these things are some of the dispensing software or some drug information software that's available and in some sites. Here's another chart that's kind of hard to see, but this just points out that many of these drugs are used for the same indication. There's a few minor differences that you see in some of them there that's on the chart. Here's a list of the SSRIs with the generic name on the left and the brand name on the right. I'm not going to read all of them off, but that's just for your information. Also, here's a list of SNRIs, or Selective Serotonin Norepinephrine Reuptake Inhibitors, which have both actions of selective serotonin inhibition plus norepinephrine inhibition, and we're confining our discussion today, of course, to SSRIs. Other uses of SSRIs are also used in anxiety disorders, panic, OCD, those things you see listed there. None of them are really superior to the other, but are based primarily on patient response, other drugs they're using, and all those considerations that we're going to be talking about. They can be used during the luteal phase. Some problems occur, sexual problems, in both males and females, such as those listed here. They're not preferentially recommended over SNRIs or any other second-generation antidepressant, but seem to have evolved to be the first ones of choice that a lot of people try. And this choice is based primarily on adverse event profile, drug interactions, prior history of response to the patient, and the cost involved. Now here's a daily dose chart that we fixed up for you to show that there are different doses of these particular drugs. The starting dose and the ending dose are listed here, but again I encourage you to look at the patient package, the prescription drug package insert that comes with the medication for the most up-to-date and accurate information. Some of the drugs to avoid, general guidelines, are what we're going to be showing today. Specific ones depend on a lot of different things that go on with the patient. The patients have to be evaluated based on drug information and individual prescription history and disease state history and all those things that you do to evaluate a patient to begin with. Some of the interactions may not be severe, and you can adjust the dosage accordingly, or you may have to adjust some of the other drugs that a patient's taking or change altogether. Many pharmacists provide medication therapy management consultations to physicians, and ideally one of these consultations may need to take place. Can be particularly helpful to the prescriber if there's a pharmacist close by that does this, and they can evaluate the patient's medication history and let the prescriber know what the patient may be taking that could contribute to serotonin syndrome or other problems that they could have with the other medications. The patient should let the prescriber know all medications they're taking, actually including OTC, herbs, and all the other things that they may be taking that are interactors. For example, isoniazid is contraindicated for use with green tea. SSRIs are contraindicated with particular drugs that we're going to talk about today too. Not all, it's complicated as well because not all the drugs in each category interact. And so here are generally some drugs to avoid, which is just about everything when you look at it. But again, it depends on patient history, other drugs the patient is taking, and the patient reaction to the SSRI, which you need to monitor closely when the patient first starts. Here's a few drugs listed that increase serotonin activity and therefore would be important to know if a patient was taking them. Here are some natural products that there are possible interactions that have been looked at in some of the literature. 5-HTP that people take for migraine, for example, is one. SAMe that people take for arthritis and depression, and which could risk serotonin syndrome. St. John's wort that some people take for depression. St. John's wort is problematic with several different drugs, and as I opened my mail just this morning, I saw from the FDA a warning about patients taking any kind of over-the-counter drugs, and particularly natural products with their prescription medications, because the potential interaction that they have, and there's so much that's not known. Folate, on the other hand, folates could be beneficial and seem to help utilization of the SSRIs if there is a minor need to enhance that. Folate might be one thing to consider. Another difficult thing about side effects is that not all SSRIs produce all of the side effects that you will come in contact with. And not everybody who takes an SSRI have side effects. Some patients don't have any side effects. And some side effects, in addition to that, some will have them to begin with, and they'll disappear rather quickly, and they'll not be very bothersome. Other side effects, on the other hand, may continue throughout treatment, and here is where you have to decide which side effects are bothersome enough to stop, or which can be tolerated, and which can cause real problems that you have to stop or change drugs or change the dosage or something like that. Of course, the elderly may be much more sensitive to them than other age groups, as well as younger children in pediatrics and infants, for example. If the side effect is severe or not tolerable, the physician should be contacted for a dosage adjustment or a medication adjustment and so forth. If you're not sure that the side effects are from the meds or from a condition or anything else, we always recommend to contact the physician, and again, a medication therapy management consultation with a pharmacist can help reveal some problems that may be caused with by utilization of them. Some bothersome side effects are listed here. I'm not going to list all of them. They're on your chart there. Apathy, appetite loss, body aches, constipation, and so forth are bothersome. They may be tolerable, or they may dissipate over time. And here's another pretty busy chart that just shows you that these are the top 20 adverse reaction or side effects that people have, and the percent prevalence with those particular drugs. Again, the package insert is your best quick reference and definitive reference. Now, these are rare but serious adverse drug reactions that we have listed here. Serotonin syndrome is possible with all SSRIs in particular. Also, we mentioned previously a prolonged QT interval, and the drugs that are listed on the right-hand side correspond and seem to be the ones, according to the literature, that most often cause the side effect on the left. And again, if they're not serious, they're transient or mild, they're something that you could expect but deal with. Serious side effects, on the other hand, are pretty concerning. Anything like chest pain, palpitations, or irregular heartbeat, vision disturbances, confusion, tremor, and muscle spasm, and so forth, all may indicate serotonin syndrome and should be dealt with right away. QT interval prolongation, any patient that's prone to that should be monitored really closely and avoid citalopram, and also fluoxetine is mentioned later on. Torsades de pointes has been reported. Most common side effects include those listed here: nausea, diarrhea, and so forth. Sertraline seems to have a higher incidence of GI problems than the others that was mentioned in the literature. Sexual dysfunction is another problem that some patients may have. As you see in both men and women, the problems are listed there. Paroxetine was mentioned in the literature as seemed to have the highest rate of these particular type of side effects. Bleeding or impaired platelet aggregation due to serotonin depletion may increase your bleeding list. Epistaxis is the most common of these, with GI bleeding with combo antiplatelet drugs and aspirin, and you can expect that sometimes with NSAIDs as well. Hyponatremia from inappropriate antidiuretic hormone secretion, serotonin with sodium levels less than 110 mmol. Those are particularly bothersome in the elderly patients. And then you have dermatologic possible side effects all the way up to Stevens-Johnson syndrome, toxic epidural necrolysis, and so forth, of course are very serious, and you have to deal with those rapidly. Neonatal abstinence syndrome can result in poor feeding, hypoglycemia, lethargy, and all those things that are mentioned there in infants that are exposed to SSRIs in utero, and we'll discuss that a little bit more later. When treating a pregnant person with an SSRI, particularly during the third trimester, many physicians consider risk and benefits of continuing on, and if feasible and possible, taking the half-life into consideration, may want to taper the dose prior to delivery in order to avoid the effects on the fetus. All of the SSRIs interact with those drugs listed there, MAOIs, triptans, linezolid, tramadol, which can all increase the risk of serotonin syndrome. Fluoxetine and fluvoxamine interact with alprazolam and increase plasma concentrations and half-life of the alprazolam. So you see, it's not always a problem with the SSRI itself. They may affect utilization of other drugs as well. Those listed there, fluoxetine, fluvoxamine, paroxetine, interact with beta blockers, which may increase beta blocker concentration, which could lead to heart block and bradycardia. Those also interact with carbamazepine, increase the concentration of carbamazepine. So it's not always the SSRI that may be increased or altered, it's the other drugs. As we mentioned before, MAOIs are not recommended, contraindicating patients with utilizing SSRIs, and should not be utilized within recommended 2 weeks of their discontinuance. And of course, interactions are common with other SSRIs, SNRIs, and any drug that affects the serotonergic system. Mepridine and triptans are the most antidepressants. Amphetamines and all those listed here are some of the ones that interact in particular. There are others, but these are the most active, it seems to be. It should not be co-administered with another SSRI or SNRI, as the risk for serotonin syndrome or neuroleptic malignant syndrome is greatly increased, and you need to monitor the patients closely for serotonin syndrome, and you need to do this particularly early on in initiating therapy, particularly if there is any chance that you don't know all the other drugs that a patient is taking, and you may have a problem on your hands without even knowing it, so that monitoring is recommended. Anticoagulants, antiplatelet drugs, nonsteroidals and all should be administered with caution. Anytime you add a drug to a warfarin, for example, you need to monitor the warfarin closely, more closely to begin with, and it's especially problematic with the elderly population. Signs should be monitored for and symptoms of bleeding, particularly if they're on other anticoagulant medication in addition to the warfarin, and of course that should be promptly coordinated with the physician. CYP450 enzymes in general, some of them that interact are listed here. Fluoxetine and paroxetine inhibit CYP2D6, thereby decreasing the drug levels. And those listed there interact with tricyclic antidepressants, antipsychotics, propranolol, and warfarin. The important thing is to monitor the patient. QT prolongation, as we mentioned before, citalopram is particularly mentioned a lot in the literature. Fluoxetine is one also, and one of the things with fluoxetine that we'll talk about is the long half-life with fluoxetine. The CYP2C19 inhibitors are bothersome, and recommended daily dose is 20 milligrams due to the problem of QT prolongation that could occur with some of those. Here are a safety issues chart that we have here for you, and some of which shows across the top you see the SSRIs listed, And on the side you see some of the problems that you could have with safety issues and some of the recommendations there. Again, patient package insert, look at the drug, monitor the patient is most important. Increased risk of suicide, primarily with all antidepressants, but particularly in children and young adults, especially in the first few months of therapy, and aggressive monitoring and is recommended for, especially for that age group, although with all patients it's recommended that you monitor for some period of time, particularly bothersome in those mentioned. The AACP, the risk-benefit ratio needs to be favorable, and you can only find that out with close monitoring when you first start. Careful monitoring for all patients when you first start the SSRI. Citalopram can prolong the QT interval, as mentioned. It's not recommended in patients with congenital long QT syndrome, bradycardia, or other uncorrected electrolyte imbalances, or using other drugs that prolong QT interval, such as fluoroquinolones. Other poor metabolizers of CYP, 2C19, you'd want to use the maximum dose of 20 milligrams per day. Frequent monitoring if you have to have concurrent use. In pregnancy, paroxetine is category D. Most of the rest of them are in category C, although septal heart defects, when mothers are taking those two particular mentioned there, sertraline or citalopram in early pregnancy, has been noted. Persistent pulmonary hypertension of newborn with maternal use after 20 weeks. Therefore, the third trimester could be associated with neonatal abstinence syndrome after delivery, which is why some prescribers try to taper them off, at least lower the dose, or maybe taper off completely, depending on the individual patient situation. Breastfeeding, again, you need to weigh the benefits against the risk. Sertraline and paroxetine and nortriptyline may be preferred due to low concentrations. Abrupt discontinuation is also recommended to be avoided. Possible flu-like symptoms can be noticed if you have abrupt discontinuation. You need to gradually taper them down off of these drugs. Paroxetine, you need to withdraw over 2 weeks and so forth. However, fluoxetine or Prozac seems to have the lowest rate because of the slow metabolism. It stays in the system up to at least 2 weeks and has a slow dissipation, so you wouldn't have as much problem with abrupt discontinuation as you would with the ones that clear the system a lot faster. Not recommended in bipolar disorder. It may precipitate mania and some of those problems when patients use that, have that problem, so you may want to use some other drugs. Monitoring, we mentioned monitoring several different times. If a patient has side effects or problems, they'll show substantial improvement, primarily during the first 2 weeks. Sometimes not up until a month, so I'd talk to the patients if they're having side effects, as we mentioned before. If they're minor or tolerable, encourage them to continue on, and which they'll either be able to tolerate them or they will dissipate and won't even notice them after a period of time. And therapeutic response is the same way. It may not give immediate relief of whatever the problem is, but encourage them to continue for a month, month and a half, sometimes 2 months in order to get the full effect and see how it's going to going to affect them. Electrolyte measurements need to be taken, especially in patients that are at risk for that, maybe kidney problems, elderly, so forth like that. And sometimes an ECG is recommended for QT prolongation. Certainly dosage would need to be reduced if you're going to have to use those that contributed to that. Serotonin syndrome, part of the monitoring that needs to go on right to begin with. Signs and symptoms of serotonin syndrome include mental status changes, tachycardia, coordination, nausea, vomiting, and diarrhea. You need to proceed slowly with patients and counsel the patients and talk to the patients about alertness and coordination until they fully realize how they're going to affect them, or either if they are problematic, they will dissipate, and see how that goes. We'll talk about that a little bit later on when we talk about elderly response, because they seem to have the most problems with coordination. MAOI inhibitors, best to avoid or either not use within 14 days of initiating therapy. Of course, any of these that are listed here, worsening depression, suicidal ideation, agitation, and all of those, certainly need to be monitored, looked at. The prescriber needs to know that that's going on. If you see a patient that was prescribed these and they're not your patient, and maybe it might warrant letting the prescriber know that the patient is having these problems. And they may look at a change in therapy or a dosage change and so forth. You need to counsel the patient also to report any symptoms that they're having that may be associated with QT prolongation. Those listed there are palpitations, dizziness, and so forth, especially with the two drugs that are the most seem to be, according to the literature, the most problematic, which is citalopram and fluoxetine. And they need to be told also it may cause sexual dysfunction, which would be concerning to some patients. Symptomatic improvement may not be seen for a few weeks. There again, the patient should be counseled that they may not get the full effect for several weeks or maybe even a month or so. So hang in there with it. Encourage them to try it. I don't know how many patients that I've told that I have seen over the years that said, well, they started taking it. It was not doing that much, and I'll encourage them to hang in there and wait for a month or sometimes 2 months before they try to give up on it. But certainly contact the prescriber if there's anything really bothersome going on. Signs and symptoms of serotonin syndrome, again, high fever, agitation, confusion, hallucinations, hyperreflexia, muscle problems, nausea, vomiting, diarrhea, and so forth. Other serotonergic agents that can precipitate or contribute to this are listed here. Certainly other SSRIs, along with those listed, to mention any tramadol or any opioid, certainly St. John's wort, or any of the natural products that people use may contribute to all of this. Signs of hyponatremia, which could be difficulty, confusion, headache, memory impairment, weakness, and all of that, unsteadiness, especially bothersome with fluoxetine, fluvoxamine, and sertraline. Need to be reported to the physician. Any kind of problems like that right away. Also decreased appetite and weight loss. Other things that the patient needs to know about that would be a major counseling point for the patient would be skin rash with or without symptomatic problems, and then anything like fever, edema, and so forth, coughing, any kind of pulmonary problems. Prior to new drug use, the particular notice I saw this morning recommended that before a patient uses any kind of over-the-counter or any kind of natural product, is what it was talking about, any herbal drug, certainly the physician should be consulted, and they can have a good relationship with most of the pharmacists, and the pharmacist can also provide good information to them about some of those products, or can find out about it for them if they're not sure. Sudden discontinuation, you have those withdrawal symptoms that we mentioned. They can really be bothersome, and so tapering is recommended in most cases. Don't drink. The best advice, don't drink alcohol. I know to some people this is concerning, but alcohol can exacerbate some of the problems, as you can imagine, and the best advice is to not drink. And when you have concomitant use with nonsteroidals and anticoagulants and so forth, you certainly have an increased risk of bleeding that should be monitored for, and the patient should be tuned into this early on so that they can notice and be careful. As far as instructions to the patient for administration, citalopram, escitalopram, and fluoxetine can be taken in the morning or evening without regard to the food, either one. Fluvoxamine is best taken at bedtime. And if you have an extended release of any type of substance, it's not good to crush or chew them, or because it might interfere with the release in the capsules, and you might get it all flooded in your system all at one time, and it doesn't release slowly like it's intended to. Also, the patient should be instructed to if they are on 100 milligrams of immediate release tablets, or 2 separate doses, to divide those doses up. And what we recommend is that if the 2 doses are of unequal size, to be taken daily. The larger dose primarily would be taken at night, because of the side effects that are the problems that may be had with it, and then the lower dose in the daytime. It's going to average out over that period of time, but that's what we recommend. Paroxetine can be administered as a single dose without regard to food, and usually most people take it in the morning. If you have a suspension, a lot of them you're able to put in suspension, or they have a suspension for them. Make sure on any suspension, whether it's for this drug or any other drug, make sure that if it's a suspension, you remind the patient to shake well before they use it, but in case the suspension has settled out a little bit. If you shake it up, you get a more accurate dose. And again, don't crush, chew, or swallow or chew control release tablets. You need them to be swallowed whole. For sertraline, oral concentrate, you can dilute into 4 ounces, or which is a half a cup, by using water, ginger ale, lemon lime, lemonade, orange juice. And you need to instruct the patient to dilute it immediately before use. Do not mix it in advance and let it sit there. A lot of things could happen. Maybe it'll settle out and so forth. So now serotonin syndrome. This is most concerning and needs to be dealt with immediately. If you may see a patient that you're seeing for something else, like in one of our clinics, that may be having some of these problems. And if you talk to them, or if you get a medication history prior to giving them anything that you're going to be giving them, or whatever the problem is there at one of our clinics for, these three are primarily the type of problems that you will see in a patient that has serotonin syndrome or is having problems with concentration. Central and peripheral serotonin receptors are overstimulated through the action of medications of drugs is what causes it. The incidence is not known, but serotonin syndrome is not really common and is rare, but it is very serious and needs to be dealt with immediately. Some of the diagnostic criteria are nonspecific, which makes it difficult. And again, if there are really mild symptoms and they can be tolerated, you don't have to respond to those like you do the worst ones. A hallmark sign is clonus, or involuntary rapid muscle contraction and relaxation, or tremor. The other symptoms here, as we see, are mental status changes such as pressured speech, hypomania, hypervigilant, hyperactivity, hallucinations, delirium, confusion, and agitations. They need to be dealt with right away. Most likely, if a patient is having any of those to any degree, they're going to be dealt with right away anyway, whether it's this or something else that's causing them. Of the autonomic changes that can occur in serotonin syndrome include diarrhea, mydriasis, fever, flushing, increased bowel sounds if you're examining a patient, the respiratory rate, and tearing. Tearing is interesting to me because I don't think you see that in a lot of things, and that may be a sign of serotonin syndrome. The neuromuscular effects, on the other hand, are hyperreflexia, increased muscle tone, restlessness, rhabdomyolysis, rigidity, shivering, spontaneous, inducible or ocular clonus, and tremor. These occur typically after an increase in dose of the medication they're taking or an addition of another serotonergic drug of the other ones that were mentioned. Which is why you need to monitor the patients and keep close monitoring of them for at least a week or two every time something's changed or added or something like that. About 67% of the symptoms occur within 6 hours and up to 75% within 24 hours. Fairly quick. Mild serotonin syndrome may not be recognized. You may have some mild symptoms, and that's why a lot of times those mild symptoms will go unnoticed or not need to be dealt with if they're tolerable and the patient doesn't have a particular problem with them. With increased temperature and muscle rigidity, you certainly have something that's really serious, and if it's really pronounced, you really need to consider this a medical emergency, as you can have multi-organ failure within a few hours if it continues and gets a whole lot worse. It needs to be dealt with right away. It can occur also upon discontinuance of some of the long-acting medications, Prozac or Serafim, MAOI inhibitors, and so forth. Some of the causes of serotonin syndrome, and you can think back to the graphic that we put up there, the two synapses of all those different things that affect the production of serotonin. They are all affected, and these are some of the things that are affected in that graphic that may affect serotonin syndrome, such as increased serotonin production, inhibition of serotonin reuptake in those sites, those synapses that you selectively inhibit, inhibition of serotonin metabolism if it's not metabolized properly in the body or something changes your metabolism, it could increase serotonin in the body. You could also have increased serotonin release and stimulation of the serotonin receptors, not necessarily by the drug they're taking. Two or more drugs that affect serotonin system through different mechanisms can also affect it and increase serotonin production, inhibition of serotonin metabolism, increased serotonin release, stimulation of serotonin receptors, and multiple mechanisms can also occur of all of those that would contribute to serotonin syndrome. Increased serotonin production can be caused by increased serotonin precursor. Also, inhibition of serotonin reuptake can occur from some of the drugs listed here. When you're looking at the drugs a person takes that can affect serotonin concentration, all of these need to be taken into consideration, and that's why you need a complete medication history and monitoring upon addition of other medications. Herbs and natural products are particularly concerned because they need to be told not to take any of those while they're taking this. Another good one to remember is Robitussin DM. If they got a cough, they're taking Robitussin and other medications that they may be added, such as Mepridine, Methadone, and so forth, those listed there, Effexor. Inhibition of serotonin metabolism occurs with MAO inhibitors, such as Marplan, Nardil, Eldepril, and those listed there, Parnate. Increased serotonin release occurs with the dextromethorphan and Mepridine, Methadone. And then we have the illicit drugs that people take. Methylene dioxymethamphetamine, commonly known as MDMA or ecstasy, is particularly problematic and can increase serotonin release. And then Remeron is another illicit drug. Also, stimulation of serotonin receptors by drugs that are not necessarily SSRIs or in any other class. Buspirone, lysergic acid diethylamide, or LSD, pretty common during the 60s, not as much so now, but it's still out there. Mepridine, lithium, metoclopramide, and DHE45 is another one, and the triptans that people take. The occurrence has affected elimination of a serotonergic drug which is altered. SSRIs can inhibit tramadol by CYP2D6 inhibition, increasing serotonergic activity. You need to see the interaction chart. Again, the patient package insert, the drug package insert is most important to familiarize yourself with. I always look at them every chance I get in order to refresh my memory and to know what's going on with the patient. Inhibition of serotonin reuptake are some of the drugs listed here. Again, some of the ones that are over-the-counter, chlorotrimazole, Robitussin, St. John's wort, and then some of the prescription drugs there, Flexeril, and so forth. Inhibition of serotonin reuptake here again, tramadol, trazodone, the tricyclic antidepressants, many numerous, Effexor, and then increased serotonin release, as mentioned, dextromethorphan again, Robitussin or Delsim can be particularly problematic for this as well as some of the others that are listed there. Stimulation of serotonin receptors sometimes are achieved by these drugs listed here, and that will affect the serotonin concentration and may cause serotonin syndrome. Won't dwell on those too long. Some of the treatment for serotonin syndrome is to discontinue the offending drug, which could be difficult to identify sometimes, because it may be multiple drugs, or it may be one or more or less. So you've got to monitor, you've got to figure that out if they're having serotonin syndrome. Certainly reducing the dose or stopping the SSRI would be called for in many cases. Mild to moderate cases usually resolve in 24 to 72 hours. Sometimes benzodiazepines are given to reduce hypertonicity and so forth. In severe cases of SSRI, sedation, paralyzation, and intubation may be called for, which is very serious, life-threatening. Fever, on the other hand, may be seen, and it's generally caused by excessive muscular activity, clonus and things like that. It's not a change in hypothalamic temperature set point that antipyretic would be called for. So antipyretics are not necessarily helpful in this case. To change or reduce the dose or use an antagonist, which we have listed here, would help with that. Relatively few patients get serotonin syndrome, as we mentioned earlier, but they do have symptoms that have to be dealt with on occasion if they're severe. Fatalities are rare, and improvement is seen primarily with supportive care. There's no way to predict it. Everybody and every drug is subject to it depending on the patient's individual situation. Some combinations have been identified: tramadol, opioids, and other antidepressants you need to monitor. Linezolid, another one that may be problematic. You need to avoid adding it up to 2 weeks of use and up to 5 weeks for at least fluoxetine. There was an FDA alert for the triptans, particularly here not long ago, for use with SSRIs or SNRIs. However, the incidence was low, and the patient should be educated again, counseled, and told about them, what to look for, and what problems they could have, and how to avoid them. Avoid unnecessary combinations. Again, counsel the patient. Make sure they know about the over-the-counter stuff. The prescriber should be contacted even for mild symptoms, even if you don't think that it might be the beginning of serotonin syndrome. They need to be notified. If they're severe, of course, they need to be discontinued and dealt with immediately. And I see that we've been an hour, and we're going to take about a 10-minute break here at the hour. And when we come back, we'll be talking about SSRIs and pregnancy and a few other things. So enjoy your break, and we'll be back in about 10. Welcome back. And now we are going to discuss SSRIs and pregnancy. SSRIs are probably the most prescribed during pregnancy. At least that's what some of the literature shows. Of course, the risk needs to be weighed against the benefits. And it's noted that preterm birth rates are not clearly defined as whether SSRI affects that or not. Congenital malformations, which are sometimes a problem. Paroxetine is probably the one that's mentioned most, with a cardiac risk of about 2%. In congenital malformations, 1% in all infants. Autism has not been clearly defined by the studies that we saw, and so it's not something that would be particularly concerning, I don't think. It doesn't appear to affect that at all. The risks and benefits, of course, need to be considered in use in breast milk production and in nursing by the mothers. You certainly need to take in consideration the need by the mother for the SSRI. If the mother has a tremendous need for that, you may have to look at those benefits that she may have against the potential effects on milk production and the amount of drug excreted into the human milk, the extent of oral absorption by the breastfeeding infant, and potential adverse effects on the infant. Most often occurs in the first 2 months after birth in the younger neonates. It's rare in children after 6 months or older. It particularly affects those real young ones, first 2 months. Pharmacogenetics, which is an emerging field in a lot of different things, is going to provide emerging guidance and help to make individual decisions as to the use of SSRIs in neonates and in all human beings for that matter. I highly recommend the LactMed site that's shown there, and guess what? There's an app for it. I have that app on my phone, as a matter of fact. They keep particularly up to date and do a real good job with it, and it's real easy to use, and so if you're interested in that, you can get that app. Some of the SSRIs exceeding 10% of the maternal plasma concentration are listed here according to some of the references there, and would be in the breast milk. Most common antidepressant is used in pediatric depression as well, are SSRIs. Fluoxetine is the most used with a starting dose of 10 to 20 milligram once a day, and graduating the dose up to 20 milligrams. Citalopram and sertraline have not been approved yet, and all are available in liquid formulations. However, escitalopram has been approved for use with adolescents with a starting dose of 10 to 20 milligrams. Notice something about the starting dose and the ending dose is that you start with a lower dose and go to a higher dose. And I think it's probably important to note that you sort of treat to effect with these things, and if you're getting a good effect with a lower dose, there's no particular reason to go up if you don't need to. There is, however, evidence of use in citalopram and sertraline with the dosages shown here. Again, start low and go slow up to effect. You need monitoring and follow-up for at least 4 weeks, every week for at least a month, and then every 2 weeks for about 4 weeks, and then at week 12 as indicated, depending on the patient and what's going on with the pediatric patient. And you need to continue for at least 6 to 12 months, and it's particularly important to taper when you stop giving the medication and not just abruptly stop it, because they will have, some of them may have a lot more problems than others. The side effects, again, are dose dependent and resolve with time for the most part. You need to rule out bipolar disorder. Again, that's not good for SSRIs. And some of the monitoring parameters are for agitation, disinhibition, and suicidal thoughts, which seem to be more prevalent in younger patients than in some of the older patients, although it's there with everyone. Common side effects include headaches, sleepiness, or disturbance. Again, if they are mild and transient, it's fine. If you can put up with them, some patients are going to have side effects throughout their treatment. Abrupt continuation, again, is to be avoided. It certainly could worsen depression, and also, particularly in the pediatric patient, suicidality is a real problem with abrupt discontinuation. And fluoxetine seems to have the lowest risk of abrupt continuation problems because of the long half-life, at least 2 weeks or so, and it gradually goes out of the system. So it may not be as pronounced as with one that clears the system real quickly. Citalopram is, again, a problem with QT prolongation. It should be used in caution with patients with congenital heart disease, liver disease, or arrhythmias that may also affect heart functionality. Suicidality is mentioned prominently in pediatric depression. It's mentioned in the med guide, which is dispensed with the prescriptions, and you need to weigh the benefits versus the risk, because pediatric patients have a real problem with this, and you certainly need to monitor for those things. SSRIs in the elderly, they seem to be first-line treatment in the elderly at least for a lot of patients, and there's little evidence of problems as opposed to the tricyclics, although you, again, as always, weigh the benefits against the risk. Some of the advantages for use with the elderly are fewer anticholinergic effects. There's a benign cardiovascular profile. They're easy to use, and there's safety in overdose. You've got some flux there, and you don't have a lot of differences in the form, so one is be about as good as the other. Some of the adverse effects you see in the elderly, we mentioned before, falls. That is a huge concern in the elderly, not only with SSRIs, but with many medications that are going to affect their cognitive functions. Hyponatremia is another big problem in the elderly. As we get older, of course, we know that you're having problems with your kidneys reducing their function and so forth, along with all the other stuff, and goes on with aging, and that can affect the way the SSRIs function and calls for monitoring and patient consultation, make sure the patient understands what to look for and so forth. Sexual dysfunction and drug interactions are a huge concern, the drug interactions particularly, and patient monitoring is extremely important in this group, even more so, this and young children. Again, you need to titrate slowly, particularly in the elderly, which seem to have effects a lot stronger than other folks. Start low and go slow is always a good slogan to use. Titrate to effect, and if they're getting a good effect with it, no need to go any higher. At least that's my opinion. And you need to use particularly caution with interacting drugs with the elderly. They're on a lot of different drugs, and as a general rule, and all that needs to be taken into consideration. Again, I would recommend a medication therapy management collaboration with a pharmacist to check all those out and provide input for that. Now we're going to talk a little bit about the dispensing role of the nurses in the health department. The nurses in the health department are statutorily allowed to dispense, and that's basically the reason why we initially have a pharmacist in the health department to begin with. The law was passed to allow nurses only in health departments to dispense medications, and this is done under the auspices of the Board of Pharmacy that is specifically pointed out in the law in certain disease states that we can dispense in the health department. We have added a couple since I've been here. Some of the counseling that I would recommend to the patients that nurses do, and let me make sure that everybody understands that nurses do a wonderful job in our clinics of taking care of the patients. They talk to the patients. They are very particular with the patients. They give individual care. I think you nurses that are out there and our nurse practitioners do a wonderful job with that. My hat's off to the nurses, and this is just a sort of a kind of a reminder for you, and particularly tailoring your counseling toward the use of the drug. And the drug is what we're talking about here, not necessarily the disease state, although that's part of the counseling that you do out there, I know, but just a couple of reminders about how we recommend talking to the patient about their drug therapy, and that is recognized by the Board of Pharmacy and others as a good thing to do with the patients. First of all, I would recommend discussing the uses of the drug. Make sure that the patient understands the correct use of the drug. It's important because they may not realize that this drug is specific for what they have, and many times if you talk to them and you tell them this drug is going to help the condition that you have, it is going to help clear it up, or it is going to help you with this. And when they believe that this drug is going to help what they've got, they're more likely to take it than if they are not really convinced of that. So one of the things in counseling the patient about the drugs that we try to do is to ensure that they know that the drug is going to take care of their condition, and so that they will be much more likely to be compliant. The dosage to take. Make sure that they understand clearly the doses that they're going to be taking, and especially if they're going to be taking multiple doses during the day, it's really important to be very specific about the dosage. Even more importantly, when they're taking more than one tablet a day, when they're taking 2 tablets a day, oftentimes the directions will be take 1 tablet twice a day. Well, to be more specific, I like to recommend even different than take 1 tablet morning and evening, which is pretty good to talk to them about. But even more specific, I like to list take 1 at 7 a.m. and 7 p.m. if it's 12 hours apart, or space it out and give them 10, 2, and 7 or something like that, or where it's spaced out exactly like it's supposed to be spaced out. You can never tell if you take 1 at breakfast and supper, or take 1 morning and evening. What if they sleep in regularly or irregularly? one morning they might get up at 5 and they'll say, well, I need to take this at 5. And the next morning maybe they sleep till 10, and then they'll take one. Well, you've got a 2-hour lag, and the same thing happens on the other end. Well, if they take it early or late in the morning, in the evening, they may be taking it too early or too late again, and there's a lag in therapy. So I like to recommend a specific time to take it. They may vary an hour or so, but generally if you tell them like 8 in the morning and 8 in the evening, they're going to pretty much stick to that or something close to it. At least it will be more definitive, and some of them will stick right on it. You need to tell them the dosage to take, and they'll look at these pills sometimes, and they'll see different dosages, and they'll read about different dosages. You need to explain to them they're going to be taking 100 milligrams and so forth, if that's what it is, and so that they'll understand it and understand if they need to take that. The side effects, another big problem, as we saw in the SSRIs, is that a patient may start taking something, and this is not strictly restricted to SSRIs. For example, probably less than 50% of the patients are taking their heart medication or blood pressure medication properly. Studies consistently show that many people don't take those right, and part of the reason for that is that when they start taking them, they'll start feeling tired and worn out and everything due to the reduced blood pressure. And so they'll think that maybe, this is not good, and they'll skip doses and things like that, or forget to take doses. So you need to talk to them about the side effects that they may have with these drugs, and that once they get on them and that they take them over a period of time, most of them will dissipate, and that they won't have these problems as much as if they just took them sporadically. It could even be worse. And also, again, you can reinforce the fact that taking the drug is going to help the problem that they've got, or prevent a problem from occurring, such as a stroke or heart attack or something, as in the case of blood pressure medication. So it's important to emphasize these to the patient, specifically about these, rather than just the disease state itself. Interactions, you need, as we mentioned earlier, especially with SSRIs, you need to discuss these, make sure they understand about interactions, make sure they understand that when they take something over the counter or add another drug from another doctor, how important it is to let everybody know what they're taking and to check before they add an over-the-counter drug, and especially about some of these herbs that a lot of people are starting to take or are beginning to take for different things, and they don't realize that these things can affect them. Another thing that has just come up that I've just read about, that FDA and even DEA is looking at real strongly, is the fact that a lot of these over-the-counter herbs are tainted with prescription drugs. They have stimulants in them. They have drugs for nausea mixed in with them. And they have a lot of different things. There's not a lot of regulation of those out there. So caution the patient when you're talking about interactions and so forth, and side effects, to be particularly mindful about over-the-counter drugs that they may be taking, because they may actually have prescription drugs in there, or illicit drugs that nobody knows about, and then all of a sudden the patients start having problem, and you start looking at this, oh, well, I started taking this herb a couple of weeks ago, and I've been having problems ever since. Well, everybody doesn't realize that, so that may be the problem. Another thing is to inform the patient about their drug about their drug class, about the particular type drug they're taking, why they're taking it, and all that like that. Make sure that they have a patient information leaflet, or pill as we call it, and if you have time, or if you have a particularly problematic patient that may be having problems with different things, you can take that patient information leaflet and highlight the important things in there for them, such as the dosage and such as the side effects, and tell them what to do. And once you highlight it, it sort of helps some of them to really understand about that. Also, their caregiver. If they need a caregiver, all this should be gone over with their caregiver. And so I recommend doing that before a patient takes any drugs in there that you see for any of the conditions that you see for them in the health department. So here are the references that we use to look up all this stuff with, and those are there for you to go back. And now we're going to call on Lindsay Leon, which is a PharmD candidate. She's interning now at the Medicaid Pharmacy Division, and who's going to be presenting her part of the program. Lindsay, welcome.
Well, thank you for that introduction. At this point in the presentation, I would like to delve a little deeper into what has been a controversial topic, and this is the use of antidepressants in the pregnant population. Starting with a little background information, considering that there's a significant amount of research on this topic, there's a lack of definitive guidelines for the treatment of depression in pregnant patients, which is part of the reason why controversy still remains. This controversy stems from the thalidomide crisis of the late 1950s and early 1960s. If you recall, thalidomide was prescribed to a number of pregnant patients, and this resulted in serious limb defects. Unfortunately, amitriptyline and the tricyclic antidepressants were also placed on the market around this time and were actually associated with these very obvious malformations that were actually caused by thalidomide. And to this day, the stigma remains, when in reality, other antidepressants pose a similar risk to that of antibiotics or gastrointestinal medications, though if you were to ask many pregnant patients, most would assume that antidepressants pose a higher risk to their unborn babies. So, however, the controversy is not based upon stigma alone, and complicating factors do remain for the treatment of depression in pregnancy. The two major complicating factors of depression in pregnancy are, first, the diagnosis can be difficult because if you think about it, the signs and symptoms of depression often mimic common changes that are seen in pregnancy, including mood changes, a drop in energy level, and appetite changes. Also, the second is what I plan to focus this presentation on, and this is the decision of whether or not to prescribe an antidepressant during pregnancy. Though antidepressants do not pose a risk that is as profound as that which is perceived, this risk cannot be completely overlooked. Thus, it's important to weigh the risk and benefits with each patient that you see, and to tailor this decision specifically for her. Depression, when left untreated, actually poses a similar risk to that of antidepressants. Some of the reasons behind this include poor prenatal care. Pregnancy complications are actually more common, and this can include nausea, vomiting, preeclampsia, and the use of drugs, alcohol, or nicotine, which is more common in depressed patients and can have harmful effects to the fetus. Conflicting evidence exists regarding antidepressants in pregnancy, and some studies have shown fetal malformations, cardiac defects, pulmonary hypertension, and decreased birth weight. We discussed this a little bit earlier on in the presentation, but this is just a little reminder. Antidepressant use in pregnant patients has been increasing in recent years. And when you're choosing an SSRI versus other classes of medications, SSRIs are the most commonly prescribed medications for depression in pregnancy. And this is due to their more targeted effects and less adverse effects for both the mother and the fetus. And it's important to consider avoiding the tricyclics, and that's mainly because once again, the SSRIs have a more focused treatment and do not have as many side effects. When choosing an SSRI, however, it's best to avoid Paxil or paroxetine, and this is due to teratogenic effects that include malformations to the heart. And because of these that have been seen, the FDA has actually classified paroxetine as pregnancy category D versus the others, which are pregnancy category C. The American College of Obstetricians and Gynecologists and the American Psychiatric Association have given loose recommendations for some patient populations. And note that the words in these recommendations will be loose. They will use words like may and that you should consider. And this is because there are no definitive recommendations. And the populations that they have given recommendations include women that are currently taking antidepressant medications who are thinking of becoming pregnant, pregnant women who are currently taking antidepressants, pregnant women who are exhibiting signs and symptoms of depression who are not currently taking medication for depression, and just general recommendations for all pregnant women. Women currently taking antidepressant medications who are thinking of becoming pregnant may consider discontinuation before becoming pregnant if the patient has had mild to no symptoms for 6 months or longer. They may consider discontinuation, and it may be appropriate in patients with a history, or it may not be appropriate in patients with a history of severe or recurrent depression, previous suicide attempts, and a history of psychiatric illness requiring medication. In pregnant women who are currently taking antidepressant, it's going to be important at this point to take patient preference into account and following a consultation with you or the physician or pharmacist regarding the risk and benefits of continuing treatment that we discussed a little bit earlier. You may attempt to discontinue these medications if they're not currently experiencing symptoms, but keep in mind that psychiatric history should be also be taken into account, because you wouldn't want to discontinue an antidepressant medication in someone who, for instance, had previous suicide attempts. Psychotherapy can be considered as either an adjunct or as an alternative to antidepressant therapy, and patients with severe depression should remain on medication. And that's a current severe depression. As for pregnant women who are exhibiting signs and symptoms of depression who are not currently taking medication for their depression, you may consider psychotherapy in patients that are wishing to avoid medication, and then evaluate risk and benefits on patients wishing to initiate an antidepressant regimen. So note that this is, once again, very, very loose recommendations. And finally, all pregnant women with suicidal or psychotic symptoms who have or have not experienced a history of depression, they should be referred to a psychiatrist immediately for treatment. Now, as a nurse practitioner, your role will be to look at each patient and determine whether or not an antidepressant will be appropriate in her case. Some factors to consider when making this decision are patient history, the severity of their depression, whether or not they're currently taking antidepressants, what other current medications they're taking, because as we've discussed already in this presentation, there are multiple drug interactions that are clinically relevant with this drug class. And then also you should take into account patient preference. And now, should you choose to discontinue your SSRI, it's important to devise an appropriate taper schedule to avoid those withdrawal effects that we discussed earlier. All right. Now, I would like to discuss just a case to go through so that way we can go through a stepwise approach to see how you would approach a case when someone came up with a diagnosis of depression and how you would decide whether or not to treat. So KL is a 33-year-old white female who recently found out she was pregnant. She found out she was pregnant last week and is concerned because she heard from a friend that antidepressants are bad to take while pregnant. So how would you handle this situation? The first thing we're going to want to do is to assess the nature of depression. And so the first thing you're going to want to ask yourself is, how severe is this depression? And KL has had a history of severe depression that has been improving steadily over the past 7 months. You're going to want to ask, has she had any history of suicide attempts? And in this case, KL has had no previous attempts at suicide. You're going to want to ask what medication she is currently taking, any antidepressants, and in this case, yes, she's currently on fluoxetine or Prozac 20 milligrams every morning for the past 8 months. Is she currently taking any other medications? And at this point, no, she's not, just to avoid any confounders just in this case. And then you're going to want to talk to the patient and discuss the risks and benefits so that her preference can be taken into account. And just as a reminder, some of the risk of depression while pregnant is that you may experience more pregnancy complications and poor prenatal care. And some of the risk of antidepressant therapy while pregnant include lower birth weight, respiratory problems, which is a relatively low risk, and then transient genderiness or irritability in the infant. So in a case like KL's, patient preference would play a major role. KL does not have any patient-specific factors that would firmly conclude what should be done. Keep in mind that she does have a history of severe depression, but it is not severe at the moment, and she does not have any history of suicide attempts, which would all be reasons for her to absolutely continue the medication. So at this point, you're going to want to compare the risk and develop a plan. At this point, you're going to want to take KL's preference into account. And then here are some other considerations to take in just in a general patient, whether or not to prescribe an antidepressant. And that would be the previous exposure of the fetus to an antidepressant, because if you think about it, KL has already been pregnant, and so this fetus has already been exposed to fluoxetine, which, if you recall, has a longer half-life, so it will remain in her system for an additional 2 weeks. So should she decide to discontinue this medication and maybe reinitiate it in a couple months, then the fact that the fetus has already been exposed to fluoxetine would be a reason to restart fluoxetine rather than a different SSRI. And note that a prior response would also be a question that you would want to ask, because a mother who is pregnant, if she had had a prior response to a certain SSRI, it's likely that she would have a similar response a second time around. So it would be a good idea to prescribe the same SSRI. The minimal effective dose should be maintained, so once again, start low and go slow. And then you can continue these SSRIs through delivery. There have not been any studies that have shown that continuing SSRIs through delivery have resulted in any more adverse effects than those who have stopped it. Now, here are some questions to ask when deciding whether to consider an SSRI during pregnancy. How long have you been experiencing symptoms of depression? How long has it been since you last experienced symptoms of depression? Do you have any history of severe depression or suicide attempts? Are you currently taking antidepressants? And what other current medications are you taking? And then after you've asked these questions, you will evaluate the risk of depression versus the risk of antidepressants with this individual patient, and then develop a plan with the patient, including choosing an appropriate medication, scheduling a follow-up, and reminding them of symptoms to watch, including increasing signs and symptoms of depression, and to inform their doctor if they're feeling any changes in their mood or just irritability, sleep patterns, anything of the like. And then finally, should you choose to discontinue the medication, you're going to want to develop that appropriate taper schedule because it is important not to abruptly discontinue these medications.
Okay. So that concludes our formal presentation. Do we have any questions? If you think of anything, if you think of anything, feel free to email us or let us know, and we'll be glad to respond to those. We appreciate you allowing us to come and talk to you today. Hope that this has been helpful in some way to you, and we appreciate all you do out there in our counties and in the clinics that you take care of.